I'm going to focus on the immunopathogenic mechanisms, as well as what I really do, which is biomarker discovery, and then the potential of using that information to identify potential therapeutic targets. So autoimmune paraneoplastic encephalitis is not uncommon when you bunch all of these conditions together. And in fact, the work that we did and published in 2018 looked at how common these diseases are in the general population. So this is a population-based study where we studied the frequency of these diseases in a defined population in northern Minnesota. And what you can see here is that between 1995 and 2005, the prevalence of autoimmune encephalitis was about half of that of infectious encephalitis. But over the last 15 years, what you will notice is that that has changed. And the reason that has changed is because firstly, we've become much better at making the diagnosis of autoimmune encephalitis. But secondly, there's been a dramatic advance in technological movement towards novel platforms that can allow us to identify novel biomarkers. And so the age of technology in the scientific community has advanced our ability to discover new antibodies. And this has led to an increased recognition of autoimmune encephalitis, such that now infectious encephalitis and autoimmune encephalitis have the same prevalence within the community. And I suspect that, as Dr. Najjar had alluded to, when we try and soon figure out the seronegative cases, then I suspect it will be more common than infection. Now, autoimmune encephalitis can essentially affect any part of the central nervous system. And oftentimes patients will have multifocal neurological presentations. Now, how do we make a diagnosis of autoimmune encephalitis? Well, Dr. Najjar has previously showed you the importance of neuroimaging, the importance of looking at spinal fluid. And he's also talked to you a little bit about the complexity, or the growing complexity of neural autoantibody testing. Neural autoantibodies are very important because not only can they assist you in making a definitive diagnosis, but they can actually direct you towards an appropriate treatment approach. And really the purpose of this slide is to try and show you the evolution of antibody discovery. As you can see, when I started in this field back in the mid-1990s, there were not so many antibodies at that time. And it was really, autoimmune neurology was kind of an unknown entity. There were no autoimmune neurology clinics, there were no autoimmune neurology fellowships, there were no groups coming together. And generally, autoimmune neurology was kind of buried within neuro-oncology, within other kind of specialties. But here you can see that the muscle acetylcholine receptor antibody, the biomarker for myasthenia gravis, was kind of discovered in the mid-70s. Others were subsequently discovered more in the 90s, the neuronal acetylcholine receptor antibody, which was discovered by Van der Lennen. And then you can see these other antibodies, the HU, the RE, and the YO. And when I was in medical school, these were the antibodies that everyone thought about, always had them on their differential diagnosis for a multifocal neurological presentation that was subacute. And you'll be surprised to see how rare these are in terms of the big pie of autoimmune neurological antibodies. As I said, since the 90s, there's been this just explosion of discovery, and it becomes complex. You're looking at a variety of different antibodies, and these are now colored differently. So the green antibodies, these are antibodies that indicate the target antigen is inside the cell, it's inside the living cell. And so we generally think of these antibody-associated disorders as being T-cell mediated. In other words, the antibodies are telling us something, they're a biomarker, but they're not pathogenic per se. Whereas the antibodies in red, these are antibodies that are targeting proteins or receptors or channels that are on the outside of a living cell, either a neuron or a glial cell. And these antibodies can be pathogenic. So as you can see, the complexity of this entity is really growing quite dramatically. And many of you will look and see an antibody that you might recognize, maybe NMDA receptor antibodies, maybe GABA B receptor antibodies. But there are many antibodies here that many of you may not recognize, and hopefully we can talk a little bit about some of these. Now, in the lab, we obviously have to detect antibodies, and it's important to recognize that there are some platforms that are not very good for detecting antibodies. We traditionally used to use a lot of Western blot, a lot of ELISA, a lot of immunoprecipitation. Unfortunately, these assays are not ideal. And the field is now moving towards using cells that you've actually transfected. In other words, you've put the code for that protein into a cell that generally doesn't express it. And then the protein now is expressed on that cell. And then you mix that with cells that have not been transfected. And then you put in the patient antibody and it binds. And then you put in another antibody that gives off a color. And you can look down the microscope. And as you can see here in E, you can see that these cells have the antibody, which is labeled in green, around their cell surface. And this is how we detect NMDA receptor antibodies, GABA B receptor antibodies, DPPX antibodies, etc. We can also go one step further. Rather than using our eye to look down the microscope and say that those antibodies are there and binding to the proteins that we have put into these cells, we can actually use a flow cytometer, like a computer, to actually detect these positive cells. And this increases sensitivity and specificity. And actually, we have moved toward development of flow cytometry assays, which are really, really high quality. And they also actually allow you to evaluate and assess living cells. Because as you know, we're really interested, at least when we're talking about pathogenic antibodies, we're interested in antibodies that are binding to the outside of the living cell. So when we think about antibodies that target nuclear or cytoplasmic neural proteins, in other words, in simple terms, this means that the patient has antibodies in their blood or their spinal fluid that is actually targeting proteins that are inside the nerve cell or inside the astrocyte or inside the oligodendrocyte. And just to point out before we get started, if you do an encephalitis panel, the Hu, Re, and Yo antibodies account for less than 5% of antibodies detected. So if you see a patient and you suspect that they might have a paraneoplastic neurological disorder, if you just order Hu, Re, and Yo, you'll miss 95% of the cases. Now, these are the antibodies that we're talking about at the moment. These are the antibodies that target proteins that are inside the cell. And there's many of them. Now, what does this mean? Well, this is how we think about it. So why do patients develop these autoimmune neurological disorders? In most cases, we often don't know, but in some, and we'll talk about this a little later, a tumor, and Dr. Najjar discussed many of the different types of tumors, ovarian teratomas, thymomas, small cell lung cancers, that can initiate this process. We also know that virus can initiate this process. And in other cases, we don't really know. It's probably a multifactorial combination of certain HLA subclass, as we know from Lgi1 and Caspr2 studies, and a variety of other factors. Regardless, the tumor or the virus may express or have the protein in question. The dendritic cells will go into the tumor and they will eat up the dying cells, and they will carry the proteins that are in those dying tumor cells up to the lymph node. And there, an immune process is initiated. B cells will make antibodies, and B cells and the dendritic cells also will push and drive T cells to clonally expand to specifically target that specific epitope that's within that tumor antigen. Now, what happens is, though, is that that tumor antigen is a neural antigen, and so it is also expressed in brain cells. Now, these antibodies that are made in the periphery, in the bone marrow, these antibodies are there and we can detect them. And so when you send a blood sample or spinal fluid sample, we can detect them. but they're not pathogenic. They're not causing the problem. It's the cytotoxic T cells that are causing the problem. And these cells then can travel in the blood, and then they can move into the spinal fluid space. And then when everything is right, when the correct situation occurs, and that neural cell actually now expresses the peptide from that tumor on its cell surface. And remember, that's its own peptide because these are neural peptides. The T cells then can recognize that. And once the T cell recognizes that peptide that it has now been told to hone in on, it will kill the neuron. Now, these conditions, when they're T cell mediated, these are very difficult to treat. And so early diagnosis and aggressive treatment that suppresses bone marrow cells is required to stop these disorders in their track. Also, removal of tumor sometimes can help, but generally doesn't. Now, the second scenario is where the antibodies are actually targeting plasma membrane neural proteins. And these are the antibodies that we talked about earlier. So what happens here is, again, the same scenario. It could be an ovarian teratoma with NMDA. It could be HSV infection with NMDA. Regardless, the process initiates. B cells and T cells are activated, and the B cells mature to plasmablasts and plasma cells that pump out antibodies either in the peripheral blood or in the spinal fluid space. And these antibodies are pathogenic. And what do? They have lots of potentially bad effects. So they can turn on or turn off receptors. They can bind to the target, and their Fc portion of that antibody can activate a protein called complement. I'll talk about that in a little moment. They can cause internalization, and we'll be talking about that with respect to NMDA receptor autoimmunity. It's important to note that these are the diseases that are oftentimes very reversible and very treatable. And again, early diagnosis and early treatment can result in some patients in miraculous improvements. In other patients, they may require prolonged therapy. And once we start to tease out the mechanisms that are involved in these diseases, we can start to identify precision medicines. In other words, medicines that will specifically target those targets and potentially result in benefit for patients. Now, a lot of the early work in terms of the concept of understanding mechanism and moving to near cure really came from work on neuromyelitis optica. As many of you may know, the water channel antibody was the first antibody ever discovered that was a biomarker of any form of MS-like illness. It was discovered in 2004 at Mayo Clinic. And at that time, patients with this disease, it's an antibody-mediated disease that causes blindness and paraplegia, in other words, spinal cord dysfunction. It's a very disabling disease. All these patients were generally misdiagnosed as having multiple sclerosis and were put on drugs that actually made them worse. But through studies on trying to understand the mechanism by which the aquaporin-4 antibody, the water channel antibody, by which that antibody causes damage, it actually led to identification of novel targets. So basically what's happening here, it's a very busy slide, I understand, but what's happening here is that B cells are making these aquaporin-4 antibodies, as you can see here. And these aquaporin-4 antibodies are the pathogenic antibodies. And when these antibodies go and they bind to the water channels on the astrocyte, they can do a lot of things. They can activate complement, and the complement can kill the astrocyte or release a lot of inflammatory factors that cause a lot of inflammation in the brain. They can also bind to the target and cause it to be internalized or modulated off the cell surface. And so drugs that stop the production of aquaporin-4 IgG through inhibition of the interleukin-6 receptor or through inhibition of the CD19 protein on B cells, these drugs potentially, you would think, you would hypothesize, would help in the disease. And in fact, phase 3 trials have now been completed and show that these medications result in about an 80% reduction in the likelihood of having a clinical attack in this disease. Also, as you can see, if you block complement, that also potentially can result in significant improvement. And the use of eculizumab as a preventive medication in this disease also has been shown in a phase 3 trial to result in significant reduction in the likelihood of a clinical attack. So the point here is that understanding the mechanisms by which these antibodies potentially have pathogenic effects is complex, but it is the way forward in terms of identifying specific therapeutic targets for treatment. So this is a disease that's considered an orphan disease. There's probably about 500,000 people with this disease in the world. And this was a devastating disease with 50% of people being in a wheelchair after 5 years, 50% of people being dead after 5 years, 30% of people dying from respiratory failure. And now we have 3 drugs that are FDA approved. And this is really an important landmark kind of disease that I think sets the stage for dramatic advances with respect to all of the other diseases that we're talking about now, the autoimmune encephalitides. This is just another example of a mechanism. Again, very nice work from Joseph Dalmau, who really put the disease anti-NMDA receptor encephalitis on the map. And here you can see this is an example of if you take a patient's blood with the NMDA receptor antibodies on it or spinal fluid with the antibodies present, and you put them on a live hippocampal neuron that's growing in a cell culture, you can see that you dramatically down-regulate the NMDA receptor off the cell surface, as you can see here in the right. You can also take the antibodies from a patient and put them into an animal, inject them into the ventricle of the animal, and the animal will develop memory deficits, depression-like behavior, etc. And you can also show that when these antibodies have this effect on the NMDA receptor, they have a significant impact on the NMDA receptor-mediated electrophysiology and currents. And interestingly, the way this works is that the antibody binds to a protein that anchors the NMDA receptor onto the cell surface. And when that antibody, the pathogenic antibody, prevents that interaction, the NMDA receptor is actually internalized. This is an example of work that was mainly done by Suresh Irani and his group at Oxford. This was from an editorial that I wrote with Anastasia Zakharadu. And it just outlines some of the work that Suresh had done. Basically, the voltage-gated potassium channel complex is a complex of proteins that are involved in synaptic connectivity. And what you can see here is that there are 2 types of antibodies identified in Dr. Irani's study of Lgi1 antibodies. There are antibodies to the EPTP here, and you can see here that they block the interaction between the ADAM22 and ADAM23 and the Lgi1. And then the LRO antibodies, these are another type of Lgi1 antibodies. These antibodies actually block the Lgi1 and Lgi1 interaction, and thus they prevent that synaptic connectivity. And that's what leads to the patients having seizures and encephalopathy. And also similarly, this is work from UPenn, which shows the impact of the antibodies in terms of the Caspr2, also in a voltage-gated potassium channel complex antibody, and how the antibody can have a functional effect, a functional obstruction of the of this complex. So when we think about encephalitis antibodies, as you can see, there's lots of them. These are the ones that are most pertinent to encephalitis. And obviously, there's so many antibodies, you wonder how could a doctor know which antibody to test? And that's why we have developed evaluations. The concept of a cover-all test. You order one blood test and you basically cover all the potential antibodies. And actually, this is a study that we did recently where we looked at all the positive antibodies from about 50,000 patients that underwent an autoimmune encephalopathy evaluation. And it gives you some interesting results. If you look at children, you can see most children with encephalitis who are having a spinal fluid test. Now, remember that MOG antibodies are not tested in spinal fluid at the current time, but most of the antibodies are NMDA receptor antibodies. But when you look at adults in spinal fluid, you can see that there's other big groups here at play. GAD65, 20% in spinal fluid. And then Lgi1, also a big player. And when you look at serum, you can see that the NMDA, the GAD65, and and Lgi1, these are the three big players in terms of encephalitis in adults. And then these rarer ones, you can see these make up a smaller piece of the pie. But it's interesting also to look at the frequency of MOG. In fact, if you look at how common MOG is in children, if you look at serum antibody biomarkers of encephalitis, 22% of them are MOG antibodies. Now, why is it important to have comprehensive evaluations? Well, the reason is that though there are some subtleties and there are some clinical characteristics that can direct you towards one antibody or another, the reality is that in general practice, that's not also oftentimes that helpful. So yes, facial-brachial dystonic seizures will point you towards Lgi1, but most patients with Lgi1 antibody-associated encephalitis don't have facial-brachial dystonic seizures. And many patients can present with psychiatric manifestations and have other forms of limbic encephalitis. And this just shows you, at least from an imaging perspective, you would not be able to tell which antibody is causing the problem here because the imaging looks similar in all these different specific cases, despite the fact that each of these antibodies has a very different implication for the patient. This is an example of a 74-year-old woman who came in with a rapidly progressive encephalopathy. She had an inflammatory spinal fluid. You can see that she had evidence of limbic encephalitis on her MRI. And this is what we saw in the lab. This is her antibodies binding to a mouse brain. And you can see her antibodies are binding to the hippocampus, which is the area that's inflamed, as well as other parts of the nervous system. And so this test showed that she had AMPA receptor antibodies. And she was treated and she made a complete recovery. Now that's in strong contrast to another patient, 62-year-old woman who presented quite similarly, but actually had a different staining pattern on mouse tissue that indicated she had antineuronal nuclear antibody type 1 or HU. And this patient had metastatic small cell lung cancer, and actually she had a severe neurological deficit and died. So the patients can present in similar ways, but the antibody actually will tell you not only what the problem is, what the underlying tumor is, but also potentially inform you on what type of treatment you might want to use, and also what the prognosis is. The same goes for things like movement disorders. Again, these are antibodies that are specific toward movement disorders. This is one of the classic ones. Patient, 69-year-old woman who presents with a progressive loss of balance over 6 months, wheelchair bedbound, unintentional weight loss. And here you can see the clinical exam shows that she has quite significant ataxia. She has on tissue IF, a staining pattern consistent with anti-Yo antibodies or Purkinje cell antibody type 1 antibodies. And you can see on her MRI, she has a very small cerebellum. So she's lost volume in her cerebellum. And unfortunately, this biomarker tells you that this patient has either a breast or an ovarian or a fallopian tube tumor. And unfortunately, this disease is quite resistant to therapy. If the patients come in and they're in a wheelchair, they will unfortunately remain in a wheelchair. If you are lucky enough to get a patient that walks into your office with this condition, if you treat them very aggressively, you may halt the disease. This is just another example of a new antibody that we recently discovered at Mayo called the Neurofilament light chain antibody. And you can see this is the neurological syndromes that this antibody is associated with. And 77% of the patients had malignancy. And interestingly, some of the malignancies were a little unusual, like a Merkel cell tumor here. This is another antibody that's kind of coming, will be coming soon. Quite a rarish antibody, but we did look at 10 patients, and this is the staining pattern they have on mouse tissue, as you can see here. And these patients can present with ataxia and other neurological symptoms, and sometimes may have cancer. This is another one, neurochondrin immunoglobulin. These patients can have rapidly progressive rhomboencephalitis. They may have underlying malignancy. We don't have enough patients yet to know whether there is a definitive relationship or association with tumor. But you can see what we see on tissue when we look, this beautiful staining pattern of the hippocampus, the basal ganglia, and the cerebellum. And this is another new antibody called septin-5, again, causes ataxia. You can see again the staining pattern. And this is how we oftentimes discover these novel targets. Here you can see you're using a patient antibody, you're using a monoclonal antibody, and then you show that the two co-localize on tissue. And then they also have a Western blot band at the same level. Interestingly, this was an antibody that we also tested out a proto-array approach to discovery. And here you can see the standard workup that we do to try and discover an antibody generally takes a consultant and one of our technicians about a year to a year and a half to discover and move it towards, publication. Here we used a proto-array where we essentially put 9,000 purified human proteins on a nitrocellulase-coated microarray slide, and we're able to actually discover that septin-5 was the target in 1 week. And as you may know, we recently used the concept of phage display to discover the Lgi1 antibody, which is one of the most important and frequent antibody biomarkers of ataxia in men. This is actually that type of case. This is a 41-year-old man who came in with hearing loss, double vision, and imbalance. The hearing loss is a kind of a clue to this condition. And you can see that the MRI scan was normal and the spinal fluid showed an elevated white cell. So we knew that the patient had an encephalitis. And when we looked down the microscope, we saw these little stars in the night, as you can see here, these tiny little stars in the night. And we'd seen this starting back in around 1990. And we've collected about nearly 100 cases now, but we reported 11 of them in conjunction with our colleagues at UCSF by using a phage display approach to actually discover what that target was. We'd actually been working for 2 years to try and discover this target and couldn't find it. And then working with Michael Wilson and Joe DeRisi at UCSF, they were able to discover this antibody using their phage display approach. And here you can see just once we discovered it, then we went back to the older approaches where we do co-localization. We basically put the Lgi1 into a cell and then we flagged it so we know it's there. And then we show that the patient antibodies are actually binding and co-localizing. So if you're interested, this was published in the New England Journal of Medicine. And this actually is actually not an uncommon antibody. The problem is it's very hard to detect because we often miss it when we're looking down the microscope at the tissue. But we have now developed a high throughput automated slide scanner approach to recognizing this antibody. We're hoping to offer it soon. Interestingly, this antibody-associated disorder is actually has quite a high prevalence of 2.8 per 100,000 men. So it's actually one of the more common antibodies, paraneoplastic antibodies. And interestingly, as you can see, when we detect this antibody, we basically, when we see this antibody, we call the doctor and we say, we know what's wrong with your patient. We know that and we can tell you what the tumor is. And oftentimes this allows the physician to go and hunt, and about 80% of the time they come back and say, yeah, we found it. And oftentimes it'll be a seminoma, oftentimes not often identified in the testicle, but sometimes in the mediastinal lymph nodes. So as you can see, even the biomarkers for ataxia is just expanding dramatically. And there are clues in terms of underlying etiology, but if you see a patient with ocular appendicular axial, these disorders, unfortunately, are often refractory to treatment, especially if the antibodies are targeting intracellular targets. And you can see that the synaptic autoantibody mediated cerebellar ataxias, though, where the antibodies we think are pathogenic, these may be reversible. And there are these associated malignancies to think about, as you can see here. And then clinical clues. If patients have episodic ataxia, you can think of Caspar-2. If they've coexisting Lambert-Eaton syndrome, think of doing voltage-gated calcium channel of the PQ type. If they have autoimmune thyroid disease, type 1 diabetes, pernicious anemia, epilepsy, think GAD65 antibody-associated neurological disorders. If they've diarrhea or neuropathy, think celiac disease. If they've hearing loss, think Lgi1. If they've myeloneuropathy and sensory neuronopathy, think AP3B2. If they've got dysgeusia, think mGlu1. If they've got isolated ataxia, then you're thinking more of the YO, the PCA1, the PCA-TR, which is associated with Hodgkin's lymphoma, and then the septin-5s that we've discussed. And you can see that the evaluation is growing. So if a patient comes in with an ataxia, you've got to think about doing a comprehensive profile, because as you see, these antibodies tell you very, very different things about not only the etiology, but also the underlying tumor, the types of treatment you should use, and the outcome. This is just a couple of new kids on the block. This was an antibody biomarker that was, the target was discovered by Dr. Zakaridu in the lab. And interestingly, we saw this very interesting pattern, and we hadn't seen it before. And then suddenly we saw 3 or 4 of them. And when we contacted the physician, 2 of the patients had been started on checkpoint inhibitors. And these patients had movement disorders, and look at where the antibodies are binding in the mouse brain. They're binding to the basal ganglia, which essentially is very much involved in abnormal movements. This also is an antibody that we're working on offering as a test. Dr. Najjar referred to Lgi1 autoimmunity. This is a very unusual autoimmune disorder because the neuropathology looks quite degenerative. And again, it raises the concept of the building bridges, the role of the immune system in degenerative disease, as well as psychiatric disease, as Dr. Najjar had discussed. And these patients can have unusual presentations, including sleep disorders, brainstem dysfunction, neuropsychiatric manifestations, as well as central and peripheral nerve hyperexcitability. Now, what else do these antibodies tell us about the patients that we see? Well, first of all, some of the antibodies are highly predictive of malignancy. So, for example, if you take these antibodies, so PCA1 or anti-Yo, amphophyssin, CRIM5 or CV2, AGNA or SOX1, RE, HU, PCA2, ANA3, or even if you take the AMPA receptor antibodies or the GABA B receptor antibodies, you can see that these are associated with an underlying tumor in more than 60% of patients. So if you find an antibody like this, it tells you, yes, this may be a T cell or an antibody-mediated neurological disorder or encephalitis, but it also tells you that you must look for an underlying cancer. And remember that in these disorders, the cancers are generally identified after the onset of the neurological disease, and in fact, oftentimes after the identification of that specific antibody. And actually, the specific antibody that you have directs you towards the specific cancer. So it really helps the clinician target their search for cancer. And here you can see these antibodies are directing you towards a small cell cancer. Some antibodies are not associated with a very high likelihood of malignancy, but still malignancy. And again, we generally do think that it is reasonable to look for malignancies in these cases. So NMDA receptor antibodies are associated with a tumor in 50% of cases. Lgi1 in about 5% of cases or less will have thymoma. Caspr2, less than 10% will have thymoma. If you have Lgi1 and Caspr2, then your likelihood of thymoma increases to about 25%. And Hodgkin's lymphoma, there are antibodies that you might identify in the setting of a limbic encephalitis or an ataxia. And if you have those antibodies, then you have to look for a completely different type of tumor, Hodgkin's lymphoma. And these are the thymoma markers. So what are the take-home messages from today? Paraneoplastic antibodies often occur with a broad spectrum of neurological manifestations, and neurological autoimmunity can affect every level of the neuroaxis. The number of recognized antibody markers continues to grow, so it becomes highly complex, and it really emphasizes the need to have comprehensive neural antibody testing, so that if you have a patient that comes in with ataxia and you order a test, you know that you're covering all at least of the available tests or biomarkers of autoimmune ataxia. Just like when you're doing a genetic study for a genetic ataxia, you want to be sure that you're covering all of the genes, because there's no point in just doing half an analysis. Both serum and spinal fluids should be tested for neural autoantibodies. Different antibodies are detected with different sensitivities and specificities in different specimens. For example, if you're looking for NMDA receptor antibodies, you're best to look at CSF. If you're looking for GFAP antibodies, you're best looking at CSF. If you're looking for Lgi1 antibodies, you're best looking in serum. A negative neural antibody result does not preclude an autoimmune diagnosis, and about 40% of encephalitis at the current time is seronegative. So there's lots of work to be done. And when neurological autoimmunity is suspected, start immunotherapy even before the antibodies are available. The antibodies are helpful later because they can direct you towards the appropriate relapse prevention treatment or the appropriate diagnostic workup for malignancy, and that can help. The concept of the comprehensive neural autoantibody evaluation is driven by discovery, complexity, and phenotypic overlap. And these tools do allow early diagnosis, therapeutic decision-making, and direct cancer search. I can tell you, I've seen many patients who've had Lgi1 encephalitis for a year. They have been essentially living in nursing homes, bedbound with seizures. And it's the identification of the antibody in the serum that actually allows the diagnosis to be made and get the patient on the right treatment. But obviously, these diseases need to be on the differential diagnosis at a very early stage, because this is treatable neurology. This is the scenario where you can actually make a diagnosis and make an impact, very, very significant impact. And complexity requires laboratory director neurologist knowledge of assay performance, specimen type, and antibody clusters and signatures to provide data-driven interpretations. And you will find that as time moves on, when you order a test and you get an antibody result, you will be getting a data-driven interpretation with references, and you will be given positive predictive values of, or the likelihoods of certain types of diseases and certain types of tumors. So I worked with a great group of people. When I started in 2004, I was the only person in autoimmune neurology. We now have 7 consultants focused on autoimmune neurology. We've gone from a lab that had 2 consultants to a lab with 8 consultants now. And we have a growing group of technicians, technologists, researchers, fellows, etc. So I just appreciate all of their contributions, as most of the work that I've presented comes from them and not me. So thank you very much for your attention.